Good morning, colleagues, and thank you for the warm welcome and for the invitation to join you in your meeting today. We're going to switch gears now from the respiratory system to the endocrine system, and particularly treatment of type 2 diabetes in the 21st century. We're looking at this exciting class of medications, the SGLT2 inhibitors. Who is the ideal patient? I'm just going to show my disclosure slide. And then we're going to go on to look at the story of the sodium glucose cotransporter 2 inhibitor. Type 2 diabetes is a complex condition. I can remember at medical school learning it's all about insulin resistance in the muscle and beta cell failure in the pancreas. However, over the years, we've seen that more and more systems are actually involved in the pathophysiology. And now up to 11 systems are showing abnormalities in the type 2 diabetic patient. And the newest of these that has been discovered is the kidney and what goes wrong there. The kidney filters about 162 grams of glucose over a 24-hour period, and 90% of that glucose is reabsorbed in the proximal convoluted tubule of the kidney. The other 10% is absorbed in the distal tubule. What we've seen in the diabetic patient is that this absorption seems to be almost augmented so that very little glucose is allowed to be excreted from the body at all. So, of course, this seemed a really good point of where we could perhaps have pharmacotherapeutic intervention and allow more glucose to be excreted from the body. And hence, we had the development of the SGLT2 inhibitor, which works to stop absorption of the glucose at the proximal tubule and increase excretion of the glucose in the collecting ducts. As glucose moves out, by definition, of course, sodium will have to move out. And it's possibly this natriuresis that's also added to the benefit that we're going to see with using SGLT2 inhibitors in our diabetic patient. Now, the question is, who is the ideal patient for this type of therapy? I'm sure on a daily basis you are handling diabetic patients in your practice, and they're going to come in all shapes and sizes and with all types of expectations. So who can we give this to? Male or female? Any age? Does it matter how long the patient has had diabetes for this to be effective therapy? And what their current glucose control is? And that's going to be something I'm going to chat to you about a little bit later. Is it appropriate and safe therapy for patients who are at high risk of hypoglycemia? And can patients be on other diabetic medications, particularly insulin, and still use an SGLT2 inhibitor? Of course, is there any extra benefit in our patients who are obese and have hypertension, and particularly in those who already have established cardiovascular disease or chronic kidney dysfunction? And often the million-dollar question is, will it be funded? So I'm going to take you through each of these issues and see if we've got positive answers for those. And remembering that the two products that we have in the country is dapagliflozin and empagliflozin, I'm going to show some data from the phase 3 clinical studies that answers these questions in a very, very positive light. All these studies used men and women in equal numbers, and there was a wide range of age in the adult population. Multiple countries were involved in the trials, so there seems to be good benefit across different race groups, with an average HbA1c at start of 7 to 10%. And at this stage, in terms of just pure glucose control, that is the HbA1c range that we would be talking about. But I'm going to present something a little bit later when perhaps HbA1c is not as important for the patient. Interestingly, the dapagliflozin was used from diagnosis all the way up to 15 years in patients who already been on insulin therapy to control their sugar. And it was being used in combination with a wide variety of medications, metformin, the sulfonylureas, DPP4 inhibitors, as well as insulin. And special studies looked at those populations that were obese and hypertensive. So let's look first at the HbA1c lowering when dapagliflozin was added on to other medications. And really, it is absolutely clear across the board that there was significant improvement in glucose control with the addition of this SGLT2 inhibitor, and it didn't matter what it was added to. Empagliflozin showed similar results, and here the slide shows particularly with metformin and sulfonylurea, as well as basal insulin. But studies have also shown that in combination with DPP-4 inhibitors, empagliflozin also provides good further lowering of HbA1c. We were worried about our patients who are overweight, and indeed there seemed to be a weight benefit for patients who were started on the dapagliflozin, and that again across all groups of patients on various combinations of medication in addition. And those patients with hypoglycemia. If the patient was on dapagliflozin with metformin, and this will be seen across the SGLT2 inhibitor group, there certainly was no significant increase in hypoglycemia. But of note, patients on sulfonylureas and insulin, hypoglycemia is of concern, and this has to be taken into account when patients are initiated on this type of combination therapy. I will chat about that a little bit at the end when we're looking at the possible adverse effects. One of the most exciting things I think that we've seen in using the SGLT2 inhibitors in our patients is those patients on insulin are able to actually decrease their insulin dose. And in fact, the study showed a total between group difference of 19.2 units. So you can imagine for the patient, that's wonderful, that they see an improved glucose control, improved fasting blood glucose, HbA1c reduction, but at the same time, they're actually able to cut back on their insulin. So they feel happier about that they're achieving something worthwhile. And of course, from a funding point of view, it's going to be beneficial as well. And there was, as would be expected with the natriuresis seen with these agents, a definite decrease in systolic blood pressure. And that was with patients on various types of antihypertensive agents, particularly background ACE inhibitors or angiotensin receptor blockers. Empagliflozin showed similar improvements with weight reduction and blood pressure reduction, both systolic and diastolic, across the different groups. And here there were studies looking at the different dosing of empagliflozin at 10 and 25 milligrams. And at the moment, 10 milligrams seems to give us good reduction, and that is the preferred dose. So if we go back to our original question about who we can use the SGLT2 inhibitor therapy on, certainly it seems to be all adults. Duration of diabetes does not seem to be a reason to influence not using it. At this stage, potentially HbA1c of 7 to 10% as a starting HbA1c. You can use it in patients where you're worried about hypoglycemia, but with the caveat to be careful in patients on sulfonylureas or insulin, as those medications may need to be stopped or decreased. It can be used, however, with other diabetic medications and indeed with insulin, where we have the advantage of lowering the dose. We've seen benefits of weight reduction, so it is a good choice of diabetic agent in the overweight and obese population and in the hypertensive patient. So now it's a case of asking, what about patients with established cardiovascular disease and chronic kidney disease? Will this therapy give any added advantage other than the fact it's going to lower HbA1c and blood pressure? You can remember that in the last few years, we've talked a lot about outcome trials, and this really came from the fact that there was some increased cardiovascular mortality in one of the glitazone groups back in 2006, 2007. So the FDA mandated that all new diabetic agents coming to market had to have a cardiovascular safety trial, and the SGLT2 inhibitors had to do exactly that. And here we have the three major trials, the first ones that were developed: EMPA-REG, looking at empagliflozin; CANVAS, looking at canagliflozin, which is not available in South Africa; and DECLARE, which looked at dapagliflozin. I'd like to just point out the difference in the study populations at this point. EMPA-REG enrolled almost exclusively patients who already had established cardiovascular disease. So that meant they'd already had a myocardial infarction, already had coronary stents put in, arterial coronary artery bypass graft, or a documented stroke or chronic kidney disease. The DECLARE population on the other end of the spectrum, however, had mainly patients with risk factors for cardiovascular disease, whereas only about 40% of the patients in that study had established disease. And this is probably more representative of the patients that we see in our clinical practice compared to the patients that the cardiologists are seeing. And I think that's worthwhile keeping in mind. So if we looked at what DECLARE Timmy's looked at, and very importantly as well, this study enrolled over 17,000 patients. As we've said, most patients were primary prevention, and it still showed an incredible 38% reduction in heart failure, 70% in cardiovascular mortality, and a lower prevention in the major all-cause mortality. And you can see that reflected quite clearly on the graphs here with a separation of the curves for heart failure and less so for MACE. But these are primary prevention patients. And we know from all previous studies, such as UK-PDS, where we had to look at extended data, that we probably have to follow these patients up for years to come. And then we may then see the benefit in reducing MACE. If we look at EMPA-REG, where we had somewhat less patients enrolled, but almost all had established heart disease, you can see again the benefit for reduction in heart failure, but also an incredible benefit in cardiovascular disease. There's the heart failure benefit, 35% heart failure reduction. And then all-cause mortality, 32% reduction. And here, again, possibly because of the different population group, these patients already had established disease, so we were seeing incredible secondary prevention. But it makes these drugs very, very important to consider in the management of our diabetic patient, where cardiovascular disease has been the leading cause of death. So what really gives us this benefit? This is very likely due to that increased glucose and sodium excretion in the kidneys, causing a diuresis, causing decreased intravascular volume and decreased afterload, and therefore decreased cardiac work. We see that there's also improved oxygenation in the kidneys, and that improves myocardial contractility and decreases cardiac stress. So overall, we have improved cardiac function just by using the SGLT2 inhibitors in these patients. We will also see in months to come the data coming out for improved renal function, and that will be something exciting to share as we go along. At the stage, though, that we know that for the glucose lowering property of the SGLT2 inhibitor, we do need sufficient kidney function. And at this stage in South Africa, dapagliflozin is registered to be used with a GFR of greater than 60 and empagliflozin for a GFR of greater than 45. It's not necessarily that it's going to be dangerous to the patient to use it at the lower GFR, but possibly less effective. And at this stage, that is our registration and what we recommend. So, answer to the last question, is there benefit in patients with established cardiovascular disease, chronic kidney disease, and obviously high risk of developing those complications? And that is a resounding yes. And I think this is possibly what's really making these agents the most important of the classes that have come to market in this century, that we really have to consider whether that patients won't benefit from using them. What about funding? Well, my experience is that overall we are getting funding, but I usually assume that I'm going to have to write a motivation. And what needs to be included on there is current HbA1c, weight, blood pressure, and GFR. And then to give a history of where the patient has come from in their management of diabetes and how you think this may be of benefit to them. I find that the funding is reasonable overall, and for those patients who have co-payments, because they see in many cases an improvement in their sugar control, they seem to be quite happy to pay those co-payments. But let's face it, we're not sitting in our office with a box of drugs in front of us and then deciding who we're going to dish the drug out to. We're sitting with the patient in front of us and trying to scramble and think of all the new drugs I've heard about and all the webinars in the last year. Which one am I going to use for my patient? And that is really, the challenge, that we have to have that information readily at hand that we can then make that clinical decision. So I'm going to take you through a couple of case studies to try and make this more of a real life situation, and that perhaps we can have some discussion later on. Mr. CL is a 62-year-old diabetic for many years, 15 years, and currently on insulin and metformin with poor control at 9.8%. He's getting lots of hypoglycemic episodes. The first thing I'm going to think about is I need to adjust his insulin. His blood pressure is not ideally controlled on 3 different antihypertensive agents. He has reasonable kidney function, and his LDL is at target. He's already had 2 coronary stents, and at his latest cardiology checkup, the report showed that he has a reduced ejection fraction. He also complains of mild peripheral neuropathy. So we need to consider what we might add to his regimen. Then we have Mrs. DV. She's a slightly older diabetic patient who has been on treatment for 3 years. She's on metformin and diglycoside MR, 60 milligrams daily. Also with poor control, blood pressure, again, not ideal, slightly overweight with a BMI of 28. LDL, not at target, it's at 3.4, and it should really ideally be under 1.8. And you can see simvastatin 10 milligrams is really not going to achieve much, and we need to improve that prescription for sure. She has got a reduced GFR, 45, and she also complains of peripheral neuropathy. So in deciding what to give these patients, well, this would be my prescription, something that could lower HbA1c without hypoglycemia or weight gain, and I know I'm going to improve the cardiovascular outcome. In the last few years, we've seen a real paradigm shift in terms of how we should think about treating our type 2 diabetic patients. And this really came out with a consensus statement by the American Diabetes Association and European Association for the Study of Diabetes, putting the risk and the presence of cardiovascular disease right at the top of the treatment agenda. So it's not all about this staircase that we've always been used to seeing in terms of HbA1c and adding in a drug. We've always known probably deep down that was not quite ideal. So now at diagnosis, patients will be put on metformin, and comprehensive lifestyle intervention should be initiated. And then they should be assessed, quite soon after that, or at diagnosis as well, whether they're at high risk or established condition of cardiovascular disease, chronic kidney disease, or heart failure. And this is where the whole idea of maybe HbA1c should not be the driving decision in terms of what medications that we should actually use. So we probably would wait that first 3 months of initiating metformin therapy and lifestyle and checking HbA1c and checking how the patient is doing, and then going on to the next level of saying, are they high risk? So first-line therapy, as I've mentioned, and then consider, are the patients at high risk? In other words, have they got multiple comorbidities, smoker, obesity, hypertension, not well controlled in terms of lipid levels, or do they have established cardiovascular disease, and that's already had a heart attack or coronary stent, or established chronic kidney disease in terms of reduced GFR, or do they have known heart failure or reduced ejection fraction? If the answer to that is yes, we should, and this is what the guidelines are recommending, consider our next step of therapy independently of what the HbA1c is. And in other words, you might have a patient who actually does very well in that first 3 months, and now their HbA1c is 6.7%. You're quite happy with that in a 60-year-old patient, but that patient's already had one heart attack. Now it's a case of saying, wouldn't it be of benefit to consider this cardiovascular protecting medication that is registered for this without just considering HbA1c? And that's where the paradigm shift is happening here. It might not be something that will filter through to every patient, but I think it's something we have to start talking about. If the patient isn't really particularly at high risk, they're a younger patient, there's no established disease, we would then use individual HbA1c control. And if I just go back to the previous slide in terms of what the recommendation then is, they then divide it into choosing medications depending on risk of hypoglycemia, need for weight loss, or if cost is a major issue. And I think it's reasonable to think of those groups, but often we still have to use what is on the formulary and what's most acceptable for the patient. What does our own guidelines say? Well, in fact, the SGLT2 inhibitors have been on the SEMSA guidelines since 2017 at dual therapy. So once patients are on metformin, we can consider an SGLT2 inhibitor as an alternate second-line agent and definitely as a third-line agent. If it's to be used in combination with insulin, the recommendation is here it should perhaps be initiated at a specialist level, but I'm sure once patients are stabilized and they're doing well on the combination of insulin and the SGLT2 inhibitor, they can continue with their general practitioner. So Mr. CL, the standout thing here is he has got established cardiovascular disease. He's getting lots of hypos and he has poor diabetes control despite these hypos. So I would send this patient home and ask him to do 3-day home readings. I'm going to definitely reduce his insulin and see whether premix insulin is ideal for him. Look at his diet. Perhaps he is only eating 1 meal a day, but for some reason he's injecting his premix insulin when he's not eating. So all of those details have to be looked at. But I do think he is a good candidate to start dapagliflozin 10 milligrams, as he has got a reduced ejection fraction. Once I do that, so this will be done in conjunction with reducing his insulin dose initially, but this needs to be followed up very closely because we've got to be careful that we don't reduce insulin too much and then push the patient into a ketotic state, one of the risks of SGLT2 inhibitors. So the key here is to have quite close follow-up with the patients. I also have a handout when I put a patient onto an SGLT2 inhibitor of the specific things the patient needs to look out for in terms of side effects, and I'll go through that in a moment. What would our decision be for Mrs. DV? She's poorly controlled, no established cardiovascular disease, but she has got some reduction in GFR. So there could be several agents that we could consider here as a third agent because she's not on full dose gliclazide. It's possible that we could consider increasing that. What the benefits of a SGLT2 inhibitor would definitely be there, and we'd have to consider the GFR before choosing which one to prescribe. She is overweight, so she may consider the benefits of a glucagon-like peptide-1 receptor agonist, and I think that would be reasonable to consider. I've put insulin here, but I certainly don't think that she's ready for insulin therapy with an HbA1c of 8%, and she's only on 2 oral agents and not even one at full dose. So it would certainly still be either another oral agent or a GLP-1 receptor agonist. And this is the challenge in practice, that there is a choice, particularly at the moment. Sometimes it comes down to cost. Perhaps this patient says, whatever you give me, it's got to be on the formulary because I'm not going to be able to afford a co-payment. So it's important to know what the choices are, but be able to distill that information and make that decision for the individual patient in front of you. Just a quick run through of the side effects. The most common side effects we see with the SGLT2 inhibitors are genital and urinary infections. It's important to advise the patient really the possibility of this happening because they need to let you know as soon as possible so that you can treat them with antibiotics. I find that of the patients who have an infection, they usually require one course of antibiotics, and most of those patients don't actually have another infection. When it's recurrent, unfortunately, we have to then say that perhaps they're not going to be able to tolerate this group of medication. Patients will notice when they start the medicine that they do go to the toilet more often. Remember, they're having a diuresis and they may feel more thirsty, and that's fine. They can just drink more water. But if they get sick, and during this time of COVID, we've had to advise patients if they were running temperatures or get at risk of dehydration to perhaps stop their medication for a short period, because there is a potential risk of severe dehydration. And the elderly are possibly more at risk here. Overall, however, I find if I just advise the patient that they may need to drink more water than usual, that I haven't really had any serious dehydration complications at all. I am always concerned about the addition with sulfonylurea and insulin, and I really do monitor these patients quite closely in the initial phases. And that really brings me to the end of presenting a combination of what's available, the facts that we've learned about the medication, but trying to put it into practical clinical practice, because at the end of the day, it's the patient that we want to improve, and they need to be able to feel that what they're using is overall improving their quality of life. Thank you, and I'm sure we'll be taking questions a little bit later.